Next, I will like to welcome our Dr. Nilambaree Adke Madam to the stage. Madam will guide us about the anesthesia management of COPD patients posted for laparoscopic cholecystectomy. And to chair this session, we have Dr. Rajesh Sagadpalle sir, Dr. Somnath Jadhav sir, and Dr. Satyanarayan Vatin sir. Dr. Rajesh sir is consultant anesthesiologist at Nanded and acting SAM's treasurer. Dr. Somnath Jadhav sir is a freelancing anesthesiologist at Sangli and MIRAJ. And Dr. Satyanarayan sir is a senior anesthesiologist at Isalkaranji, working since almost 44 years. We welcome you, sir. Now I request chairpersons to introduce our speakers.
Dr. Nilambaree Adke ma'am, she is DAM MD DNB Anesthesiology. She is a professor and head of the Department of Anesthesiology, VM GMC, Solapur, and PG teacher since last 17 years, and she is a ISM life member. She has publication 8 national and international journals. Area of interest is regional anesthesia, and she got a prize in best poster in ISOCON 2003. Please,
thank you, sir. At the outset, I thank MIRAJ-SANGLI ISA branch for giving me this opportunity, and especially I thank Vasudha madam and Rupali madam. So let us today see the management of COPD patient who is posted for laparoscopic cholecystectomy. So I would like to discuss this topic in following titles. First, we will see about how is the COPD pathology, how the laparoscopy and anesthesia implications are, how the patient is prepared for a laparoscopic cholecystectomy, then the anesthetic management, the complications we face perioperatively, and post-operative course. So,
please maintain silence.
We come across obstructive airways diseases patients frequently. What is the exact pathology? It is abnormal expiratory gas flow rates. And these obstructive airway diseases comprise mainly COPD, asthma, and cystic fibrosis. COPD comprises emphysema and chronic bronchitis patients. So, COPD and asthma are different because COPD has got irreversible airway obstruction, while asthma patients have reversible airway obstruction. Then age of COPD starting is about 55 around, while asthma starts quite in early age, maybe in childhood also, maybe with allergic causes. Then there is diurnal variation with asthma, and in between patient is quite normal, which is not there so with COPD patients. Then there are no triggers for COPD. It is constantly there, while asthma can be triggered by allergens, various things. The smoking history is there in COPD, which is not so in asthma. So, what is chronic bronchitis? Chronic bronchitis is defined with the presence of productive cough for more than 3 months for at least 2 consecutive years. And the main cause is cigarette smoking. While emphysema is abnormal and permanent enlargement of air spaces and terminal bronchioles with destructive changes of alveolar walls. So this leads to loss of elastic recoil of lungs, and so there happens premature airway closure during expiration at higher than normal lung volumes during exhalation. So what are the main factors? As I mentioned, smoking, dust, pollutants, then poor socioeconomic status, repeated viral infections, and alpha antitrypsin deficiency. Then typically these patients of emphysema are thin, tachypneic, elderly, breathless at rest, then hypoxic. Even though they are hypoxic, there is CO2 retention at later stages. So they are described as pink puffers. While chronic bronchitis patients are typically overweight with peripheral edema, they have poor respiratory efforts, wheeze is there, and CO2 retention is there, which is from start only. So they are described as blue bloaters, and most of the patients would have this combined picture. So this is the picture showing us how the blue bloaters and pink puffers look. So what respiratory signs preoperatively we get? There is tachypnea, more than 25 breaths per minute, pursed lip breathing and visible expiratory efforts are seen. Patients use their accessory muscles, so there is increased load and dysfunction of diaphragm and intercostal muscles may occur. So general considerations are directed at airflow obstruction with mucus hypersecretion, and these are typically exacerbated by frequent viral and bacterial infections. Here I have been allotted to management of 55 years male with COPD who is posted for laparoscopic cholecystectomy and who has wheeze and apnea. So what can be the differential diagnosis? We may get wheeze, cough, dyspnea with bronchial asthma also, cardiac asthma also, sometimes with foreign body aspiration, bronchial tumors, bronchial stenosis. These are different conditions. So here bronchial asthma, we know what is cardiac asthma. Cardiac asthma is actually a misnomer. That is a left ventricular failure which has got pathology in heart, but the signs and symptoms are there in lungs. So it is misnomer as cardiac asthma. Then now let's see the preoperative assessment. So preoperatively cardiovascular involvement may be there with right ventricular dysfunction in later stages, which is there in most of the patients, 50% of patients. And that it is because there is chronic recurrent hypoxemia. So this, of course, this hypoxemia leads to pulmonary hypertension and then right ventricular failure, that's cor pulmonary. So we need to treat right heart failure also preoperatively. Then the only therapy to decrease the right heart strain and improve long-term survival is give increasing concentrations of oxygen. If the COPD patient has resting oxygen less than 55 or less than 44 millimeters of mercury with exercise. So this denotes severity of the disease. Here our goal is to maintain PaO2 at least 60 to 65 millimeters of mercury. Sometimes non-invasive ventilation is also needed for these patients who come in a severe stage, and they may needed to give a full mask or nasal mask with BiPAP to treat their severe acute exacerbations. So preoperatively we recommend spirometry training, and that will also educate them for their post-op course. So here, so preoperative assessment is there with, as I already mentioned, one more important history is smoking, where we describe it as the pack years. It is the number of cigarette packs per day into number of years the patient is consuming. We get symptoms like shortness of breath, coughing, wheeze, sputum production. Then we should estimate the exercise tolerance by history. So here we can ask patient how breathless he is, how many stairs he can climb, how breathless he is walking on level ground or while undressing with like general activities level. So here we should treat the reversible obstructive component by bronchodilators, and if needed nebulization with bronchodilators prior to surgery should be continued. Then as there is elevated arterial CO2 at rest, with ABG is must. Also there is chronic hypoxemia which we can investigate preoperatively, and accordingly we can start our treating. Here what happens, many a times patients are being operated and we give FiO2. So the concept is that when we give increasing oxygen concentration, that may blunt the patient's hypoxic drive. But the thing is that it can happen blunting of the hypoxic drive in some patients, but mostly increase in CO2 is actually due to relative decrease in alveolar ventilation. When we give higher inspired concentration of oxygen, there is decrease in alveolar ventilation and alveolar dead space increases. So what happens when alveolar dead space increases, same time there is abolition of hypoxic pulmonary vasoconstriction. So when this HPV is abolished, the blood flow from those HPV area, because of abolishment of HPV, the blood flow will be distributed to low perfusion or low VQ areas, and so the shunt increases, and so there is a rise in PaCO2. So still, because they are chronic hypoxemic, the supplemental oxygen is must. And also with the laparoscopy like procedures, there is decrease in FRC. So to avoid hypoxemia and the fall in FRC, we must supplement patient with inspired oxygen concentration. Also, we should see for effectiveness of drugs like bronchodilators, and we should see for any need for additional treatment with inhaled steroids also along with bronchodilators. Then take the history of frequent exacerbations, whether patient had frequent hospital visits, and whether patient had received systemic steroids in last 6 months for more than 2 weeks. That makes it mandatory then to give the patient preoperatively and intraoperatively steroids. Also, there may be history of hospital admission for his previous acute respiratory failure. Now, how to proceed for his laparoscopic surgery. Routine investigations we do as CBC, electrolytes, RFT, LFT, and specific we see for ECG, chest X-ray. Then pulmonary function tests are important. Here the bedside PFTs will help us to give a general idea, like simple as madam mentioned. BHT will help us to know his cardiorespiratory reserve, basic reserve. And baseline ABG is must, echocardiography, thoracic CT scan will help us to know the severity of lesion. Then PFT in COPD, main is FE, ratio of FE1 to FVC, which normally is more than 80%. But the patient's severity or the moderate to severe COPD will be diagnosed when the FE1 is less than 80%. American Thoracic Society has given us the severity score, like when the FEV1 is more than 50% of value, that is stage 1 mild risk. When the FEV1 is between 35 to 50%, the moderate to severe disease. Less than 35% is again a severe COPD. So chest X-ray will show us about hyperinflation of lung fields. Then vascular markings are decreased, air spaces will be like bullae, episematous bullae may be seen, atelectatic changes we may see. ECG may show right heart changes like poor RV progression, right axis deviation, cor pulmonale, right ventricular hypertrophy, right bundle branch block. Then ABG may show less than 55 of oxygen, less or more than 45 more than 45 mm of mercury CO2. That needs then the improvement of his condition by giving him respiratory physiotherapy and respiratory exercises. Then PFT will also help us to know the reversibility of his airway obstructions. And as we know, all the COPD patients have typically increased total lung capacity, increased FRC, decreased FRC and increased residual volume. Sorry, increased FRC, increased residual volume, and FEV1 is decreased. These are normal lung volumes and capacities, all you know. Then these are typical flow volume loops in normal healthy patient, where the inspiration starts and we can see the curve below the baseline is inspiration and above curve is expiratory curve, which shows the FE forced expiratory flow rate us at 25%, 75%. Then this is a typical curve showing us the response to bronchodilators. Before giving bronchodilators, you can see the expiratory curve quite narrowed, which gets to normal after bronchodilator therapy. And this depicts normal flow volume, then obstructive lung diseases, how they appear. Then with tracheostenosis, which is a restrictive type, where the inspiratory curve change you can see, and restrictive defect also is seen as smallest one with restrictive defect. So flow volumes are a very good analytic investigation. Then in preoperative preparation, stopping of smoking is most important, because within first 12 to 18 hours only the carboxyhemoglobin levels will decrease and there will be improvement in oxygen carriage. And if this is continued for more than 2 weeks or up to 2 weeks, the mucociliary transport of secretions will improve, and that function is important perioperatively. Then we have to add bronchodilators like albuterol, then mucolytics to loosen the secretions, improve the patient's hydration also, correct his acid-base electrolyte balance, then continue with his anti-inflammatory drugs, and if there is cor pulmonale, treatment of that borderline cor pulmonale is essential. Patient should be trained for use of spirometry, in situ spirometry, deep breathing, voluntary deep breathing exercises. Then if indicated, if patient still has got wheezes, then we can think of giving him oral prednisolone. Then one more important point comes when there is history of upper respiratory tract infection, which is very common. Then the normal dilemma, especially for general anesthesia, then it is observed or it is seen that the even normal healthy patient has got increased responsiveness to respiratory stimuli, and which can predispose patients to laryngospasm, bronchospasm at the induction or intraoperatively. So it is always better whenever there is history of viral infections to postpone the surgery, at least elective surgery, for 1 to 2 weeks, especially 2 weeks, because this bronchial hyperreactivity should settle down. Then in case of laparoscopy, cholecystectomy, then why laparoscopy? As we all know, this is the minimal invasive surgeries and practiced everywhere. So it has got reduced pain, diaphragmatic dysfunction is less chance of ileus, then early ambulation, patients who do want to go home at the earliest possible, resume their normal activity, economic benefits and short hospital stays. So everywhere we are now have to give maximum surgeries as laparoscopic surgeries. So why, what happens with the pneumoperitoneum they created laparoscopy? There are respiratory changes, like there is increased airway pressures, decreased FRC with the distension of the abdomen, decreased pulmonary compliance, venous ventilation perfusion mismatch increases, risk of regurgitation also increases with pneumoperitoneum. Then cardiovascular changes do occur with decreased venous return and increased systemic vascular resistance, cardiac output is decreased, and risk of arrhythmias increases as there is hypercarbia. Then in cholecystectomy we give head-up position. So with head-up position, though there is direct no much decrease in FRC, but it does decrease, then there is decreased cardiac output because of decreased venous return. Then there is gas insufflation, and mostly carbon dioxide is specifically used, which leads to stretching of peritoneum, which can cause vagal stimulation, chances of bradycardia. Plus the continuous insufflation of CO2 leads to hypercarbia and acidosis. Sometimes by accidentally there is extraperitoneal gas insufflation that can lead to subcutaneous emphysema, pneumopediastinum, then pneumothorax. Then issues of anesthesia management. They are mainly pneumoperitoneum causing respiratory compromise and hypercarbia, chances of rupture of emphysematous bullae intraoperatively, pneumothorax. Then bronchospasm is the main danger, decreased venous return, accidental injury to major vessels. Now about pre-op concerns. So we should keep low airway pressures, and avoid gastric distension by keeping low airway pressure. We should maintain normocardia. Then pre-medication, antiemetic, bronchodilator puffs, analgesia. Fluids should be administered adequately and avoid hypovolemia, antiemetics. Then induction for GA. In this patient, our plan can be GA with epidural anesthesia. Before GA, we should obtain or suppress the airway reflexes by using IV lignocaine. Induction with propofol is better. And we can start giving oxygen and inhalation agents before intubation and before giving the scoline like relaxant. So you start with inhalation agents, allothane or sevoflurane, and that will give you adequate depth of anesthesia after scoline. The sevoflurane at 1.1 mag is best. Rapid bronchodilation also is its advantage. Volatile agents have direct relaxant effect on the airways, but intraoperatively in bronchospasm can occur. So bronchospasm intraoperatively does occur, then the role of giving puffs, maybe 1 or 2 puffs may not be adequate, give 7 or 8 puffs, then cause you must be treating like ETT kinking is there. Then you should deepen the level of anesthesia as they cause direct bronchodilation. Then extubate under deeper planes of anesthesia. But here deeper planes means you should first see the BP and then only increase the sevoflurane concentration. And here you can replace the ETT with LMA before extubation, so that will help you to extubate smoothly. So intraoperative bronchospasm it is seen. Nowadays, one more regional anesthetic technique which is coming up with several studies, retrospective studies and multi-center studies, that's regional, that too segmental spinal can be a promising option. So where we can go with isobaric bupivacaine along with 0.5 cc of hyperbaric bupivacaine combination at the level of T7-8 can give you adequate analgesia at that level. And so people have now questioned whether GA is must for such severe COPD patients. We can now go ahead with regional also. Post-op pain management with epidural can be done. So use of LMA for laparoscopic cholecystectomy in obese patients has also been tried, and that has been found to be conducted successfully with Procil LMA especially, so as to cover the aspiration. So this is my main message, that thoracic segmental spinal anesthesia is a nowadays good option for patients with COPD undergoing laparoscopic cholecystectomy, and that too in patients who have severe COPD condition, which gives us better hemodynamic stability, early ambulation and discharge, and patient satisfaction is high. So these are the various references which recommend regional anesthesia. Nowadays, in last 2 to 4 years, these are the segmental thoracic spinal anesthesia studies. Post-op care with chest physiotherapy and suctioning and post-operative pain relief can be given to decrease the respiratory complications. So these are our references. Thank you for giving me this opportunity.
Thank you so much, ma'am, for these excellent tips and tricks.
Thank you.
Now I would like to request escort members to take all dignitaries to the felicitation point.